we were delighted once again that Dr. Gabrielle Wilcox is presenting again her follow-on presentation. Dr. Wilcox was a school psychologist for 8 years before completing her PsyD in school psychology in 2009. She completed postdoctoral training in clinical neuropsychology, where she practiced as a licensed psychologist until joining the Wilcox School of Education at the University of Calgary. Dr. Wilcox is a registered psychologist in Alberta and a nationally certified school psychologist. Thank you, Dr. Wilcox.
Thank you, Julian. All right, so as Julian mentioned, this is part 2. As a result, I wanted to quickly do a review of last session before we got into the content for this session. So I will review quickly the rationale for CBIT, treatment considerations, evidence that it works, selecting tics to target, functional behavior assessment, and functional-based intervention. So the rationale again was that CBIT includes both functional interventions and habit reversal because we can't change things that we're not aware of. So the habit reversal focuses a lot on that awareness. Treatment considerations include the client's age. This is generally intended for individuals 8 or older. Their commitment, because this intervention actually is a lot of work. So if people aren't committed to the work, then it's not going to be effective. Comorbidities and clinician experience. Does it work? It is listed as a first-line treatment in the US and Canada and Europe. And I presented last time evidence on the long-term benefits of CBIT. So reviewing again, functional behavior assessment and intervention. So both antecedents and consequences can increase tics. So we can intervene or modify either of those, either the antecedents or the consequences, to reduce the likelihood of tics. So if we remember back to our story with Billy, we could change the antecedents in his story of the places and situations. So not going in the den after school, the people being with his sister, activities, watching television, and internal experiences were around him being tired and anxious from his school day. And all of those things increase the tics. So the interventions, again, where to not have him watch TV or not have him go into the television room after school. And then the ways that those things reinforced that was positively. After his sister made fun of him, his mom gave him unlimited TV watching until dinner and gave him lots of positive verbal reinforcement. And he also had negative reinforcement in that he got to escape his sister by having her be removed from the room. And behaviorally, punishment means that the behavior actually decreased. So in this situation, none of the consequences were a punishment for him. So again, we can change those reinforcements by not making his sister leave, instead making her apologize and behave differently, and not giving him the reward of extra TV time after he's ticking. The purpose of the reward training is to support the hard work clients are doing and to provide some extra external support to complement the internal motivation. Because again, when we're doing hard things, sometimes our internal motivation lags. And so the reward training is intended to support that. It focuses on effort rather than effectiveness. And these rewards don't have to be monetary, so they can be non-monetary, things like staying up later or picking out the family game or movie. So today we will discuss the schedule, basically what happens during the sessions, psychoeducation about tic disorders, tic hierarchies, we'll review again inconvenience reviews, talk about awareness training for both tics and premonitory urges, competing response training, self-monitoring, homework, relaxation, progress monitoring, and relapse prevention. So a lot to cover today. So the general schedule for CBIT has 8 sessions. This can be flexible, so sessions can be added if needed. The first session, you develop rapport, take history, provide that rationale for CBIT, psychoeducation, tic hierarchy, start that FBA process, go over the reward program, and begin monitoring tics. So a lot to cover in session 1. Session 2, you go over that inconvenience review, review the tick hierarchy, create an FBA for tick 1, practice habit reversal for tick 1, and go over the homework. Session 3 is the same, but you add tick 2. Session 4 is the same, adding tick 3 and diaphragmatic breathing. Session 5, the same, adding a new tick and progressive muscle relaxation. 6 and 7 are pretty much reviews, adding some relapse prevention. And then session 8, finishing up and really going over that relapse prevention plan. So during that first session, one of the things that we really try to cover is psychoeducation. So when we go over psychoeducation about tic disorders with clients and their families, we talk about the different types of tic disorders, the different types of tics, including simple motor tics, complex motor tics, simple vocal tics, and complex vocal tics. We discuss the phenomenology of tic disorders, the causes, including genetics, neurobiological and neurotransmitters, the natural progression of tics, prevalence, and comorbidities. So in the DSM-5-TR, there are 3 general types of tic disorders. So Tourette's disorder requires that the individual has multiple motor tics, 1 or more vocal tic that are not necessarily concurrent, and have persisted for more than a year, beginning before 18. Persistent or chronic motor or vocal tics requires that somebody has a single or multiple vocal or motor tics, but not both vocal and motor tics. Again, it has to have persisted for more than a year and started before 18. And then provisional tic disorder is single or multiple vocal and or motor tics that have persisted for less than a year. So it's important to note that some of these, this differentiation is somewhat arbitrary, and CBIT is really intended to support the treatment of tics, whether or not they meet diagnostic criteria for Tourette syndrome specifically. So going over the different types of tics, there are both motor and vocal tics. So simple motor tics include discrete muscle group or single movements, and the complex ones are a sequence of movements that often look intentional, remembering that anything can be a tic. Vocal tics, the simple ones, are noises or sounds, and they tend to have no meaning or content, where complex vocal tics have syllables, words, phrases, and often involve content or meaning. So some examples of these different types of tics. So for motor tics, simple motor tics include eye blinking, nose movements, shoulder shrugs, facial grimaces. And complex motor tics include things like touching, tapping, corporapraxia, which are obscene gestures, jumping, self-abusive behaviors. And vocal tics include, the simple ones include throat clearing, grunting, sniffing, animal noises. And complex vocal tics include coprolalia. But it's important to remember that this is quite rare, so the use of obscene words only occurs in about 10 to 15% of individuals with Tourette syndrome, and most people do not experience this. Echolalia, which is repeating other people's words, and palilalia, which is repeating your own words. So these are not a comprehensive list, just some examples to give you an idea about what types of things fall in the different subsections of types of tics. Most tics are preceded by a premonitory urge. So this is an inner tension. So it's sometimes referred to as the feeling similar to when you need to sneeze or when you need to itch. And in our training, to kind of get a sense about what this feels like, we had to hold our eyes open without blinking for about 20 seconds, which actually feels like quite a long time. And then when we were permitted to blink again, most of us noted that we blinked a lot. So if you think that tics are kind of like that, and when you hold back your tics, then you need to do it a lot more. Not all tics have premonitory urges, and younger children or individuals with cognitive delays are less likely to have them, or at least less likely to be able to identify them. So sometimes it's hard for people to understand and identify what their premonitory urges are. All right, so when we think too about how tics happen, so there tend to be multiple types of triggers. So there can be sensory stimuli, Specific words or phrases can trigger tics. Sometimes there are urges for children to do dangerous or forbidden feelings. Lots of times it's just a not right feeling, and you need to do the tic in order to feel right. And there's also sometimes a need for things to be evened up. There are multiple causes for tics. Genetics is one, and like most areas, it's not very simple. So there are multiple genes working together. So you can't just identify this is the gene that is related to tics or Tourette syndrome. But there is a strong hereditary component to tics. There are also higher levels of dopamine, glutamate, GABA, serotonin, and norepinephrine. So when students or people take medications for Tourette's disorder, they are really trying to normalize these neurotransmitters. And then the basal ganglia is one of the areas implicated in tics. So if we think about the basal ganglia's role again, if we think about the basal ganglia kind of like a spaghetti strainer, and the spaghetti are the tics or the movements that aren't appropriate, and the water is all of the appropriate movements that should be getting out. And people with Tourette syndrome or tic disorders, some of those strainer holes are too big. And so some of those pieces of spaghetti get out when they're not supposed to, and that's what causes tics. Also, during this psychoeducation component, we talk about the natural progression. So generally, tics start around ages 6 to 8, and then they tend to get the worst around that 11 to 12 years old, and then they tend to get somewhat better. And prevalence. So you can see here that the prevalence for Tourette's is about 1 to 8 out of 1,000. All tic disorders are about 1.5 to 3%. But tics more broadly, about 12 to 18% of the general population has tics, especially in elementary school. So most elementary school teachers are going to see some children throughout their career who have tics in their classrooms. And again, thinking about this comorbidity component, Tourette's is highly comorbid, especially with ADHD and OCD. So it's sometimes called the Tourette syndrome triad, or TS+, because of how frequently these occur together. So about 70 to 80% have at least 2 of these disorders, and 20 to 30% have all 3. So in addition to that psychoeducation, we're going to go over these tic hierarchies. So the purpose of the tic hierarchy is to help guide treatment planning. So understanding which tics are bothering people the most help us to consider which tics to review first. However, we also want to consider the client's wishes. So maybe the one that is bothering them the most isn't the one they want to work on first. So we definitely try to honor those wishes. And we also want to make sure that their first experiences in using habit reversal training is successful. And sometimes those ones that are the most bothersome are really complicated and hard. So in those cases, we might want to move that one to the second or third so they can get a sense of success about how to use habit reversal training. First, we use the initial list that you got from the Yale Global Tic Severity Scale during your diagnostic component to start to identify the tics that we should have on this list. For every tic that goes on the list, we give a SUDS rating. So it's subjective units of distress scale. For younger children, these can be faces, and for older children and adults, we can use scales of 1 to 10 about how much they interfere with their lives or bother them. And the tic hierarchy will be reviewed each session, and they'll be rated each session, because hopefully we will be reducing the severity over time. And as you go on, it's likely that there'll be new tics added to this list throughout the training. So collecting this data each week helps with our progress monitoring, which we'll talk about a little bit more later. So I just gave you a simple sample here about what a tic symptom hierarchy tracker could look like. You just list the symptoms down the side, and then each session you rate the SUDS rating so that you can have that data to help them over time. Again, we'll use this tic hierarchy to choose the tic to focus on, and we'll use it for our FBA and habit reversal training. We talked about this last time, but we also are going to engage in that inconvenience review where the individual talks about all of the things they hate about the tics. And this is, again, one of the tools to motivate them, because habit reversal training is hard work, and remembering how much tics interfere with their lives can help them to continue to work hard on that. All right, so we're going to dig in a little bit more into awareness training. So when you start awareness training with children during CBIT, you first explain the purpose of awareness training. Again, remembering that you have to know that you're about to tic or that you're ticking in order to actively make changes. So through this, we have the child describe the tic, acknowledge the tic, and then we'll move on to awareness before the tic happens. So they describe the premonitory urges or tic signals, and then we have them work towards acknowledging those tic signals. Again, the importance of the awareness training is really knowing when they're either happening or about to happen, so they know when to use their competing responses. And it's important to note that tic description is really hard. On the face, it seems like this should be a relatively easy thing to do, but it's actually quite challenging. So that's important to be patient with kids and help them be patient with themselves as they're going through this process. So first of all, the patient described the tic in great detail. So we want them to describe what is happening in every part of their body. And there are often parts of the body involved in the tic that aren't as obvious. So there are parts where things are tightening or being used that you don't see very much. So it's important to really think through how the tic progresses. We want to start with those sensations preceding the tic and go all the way until the tic is over. If the patient isn't having the tic right now, you can encourage them to fake it, to feel what's happening in their body. And then when the patient can't think of any more, you can add some suggestions about what else you see if they've missed some things. Some tips to help you with this process is before the session, it can be helpful for you to do the tic yourself and try to describe all of the parts of it, because then it will help you to notice if they've missed some things. It also really gives you some empathy for them. So if you do this, you'll notice that some of these tics are uncomfortable or even painful if you do them repeatedly. And so understanding those kinds of experiences for people can be really helpful as a clinician. And again, sometimes body parts are involved that aren't as noticeable. It's important to start from that beginning or focal point and work outward. For vocal tics, patients often describe the sound rather than what they do. So you'll need to help them go back to what's happening in their mouth, with their tongue, in their throat, and probably in their face as well during those vocal tics. And the main goal for this is to get the patient to really engage their attention and to focus what's happening on the tic. So it's less about actually the accuracy, but their attention to their body so that they can know when they should engage with the habit reversal and to identify good competing responses. So this is just an example about what a tic could look like. Get into play. All right, so you can see that's a complex motor tic. And thinking about where things are starting for her in this, don't know for sure, but it seems like it's possible that it could start from her core or tightening her stomach. Maybe not. This is something that some of this you would be able to see better in person than on this little video. But we want to find out if that's maybe where it's starting. Maybe there's some tightening on her neck. So that's something that you want to watch closely for in person and or ask her about those experiences. Then she tends to move her shoulders forward and her arms up. She straightens and rotates her arms while slightly clenching and bringing her hands together, and then straighten her hands at the end. So again, you can see that there are lots of body parts involved with this tic. And as you would work with a student, you'd want to watch to see if there are other things maybe that you can't see in this quick video, and make sure to ask them about their experiences, because there are some things that you might not be able to see that they're experiencing. You want to make sure that you capture the entirety of that tic. There are some common mistakes that clinicians make during this phase. One is jumping in too early. So we really want to let the patient work through this tic before we give them suggestions, because again, it's really about them becoming aware of it. So if we jump in and tell them about it, then they're less likely to really pay attention and understand what's going on in their body. Stopping the process too early, so having a really brief description of the tic that doesn't capture all of the body parts involved. We want to make sure that we spend enough time here to really fully capture what's happening. Not getting a thoroughly detailed description. So again, that's related to the second one, where we just have this cursory description and we haven't really taken the time we need to understand the tic. Then we engage in response detection practice. So the therapist can simulate the tic if we need to, or the patient can simulate the tics or have pretend tics to really work on practicing this if they're not ticking at that time. During this patient practice time, the therapist and the patient chat, and the patient lifts one finger every time a tic occurs. The therapist will monitor this and give feedback, and you continue working on this response detection practice until the patient's getting about 4 out of 5 correct. So during a successful response detection, the patient will tic, and then the patient will raise a finger to acknowledge the tic, and the therapist will praise the patient for successfully doing this. If they're unsuccessful, then the patient tics but doesn't acknowledge it. And during this kind of an event, then the therapist just prompts the patient. So you just said, that was a tic, remember to raise your finger. And so you're really just helping them to become more aware of when they're ticking. Common mistakes in this part include creating an unnatural environment. So especially when you're new to this, it can be easy to really stare intently at the patient, and that isn't helpful and can interfere with this process. And not giving feedback. So this is a time when sometimes being a talk therapist can interfere, because sometimes then you're too involved in the conversation, because in talk therapy, that is the key to the intervention. But in this one, the conversation or game really is just kind of a setting or a stage for the real intervention, which is helping them to identify whether or not they were successful in identifying their tics. Another reason that people don't give feedback is they don't want to interrupt. So again, if the kid's telling you a story, you need to interrupt them to say, good job, you noticed your tic, or you missed your tic, remember to raise your hand. And this tends to be a little bit easier for therapists to do more assessment or behavioral work that requires both listening, monitoring, and tracking. So if that's something new for you, make sure you give yourself some time to practice being able to do those 3 things at the same time. So after individuals are good at knowing when they're ticking during the process, we want them to start to understand when they're about to tic or their premonitory urges. So again, this is pretty similar to the tic detection, except that we want them to raise their finger before they tic. So unfortunately, the only way that we know if they had the premonitory urge is if they actually tic without identifying it. So then we would just prompt them to raise their finger when they feel the premonitory urge and or when they tic. So in this part, we really want to work towards identifying that premonitory urge. So what does it feel like inside right before they tic? And oftentimes it's this feeling of tension or almost itchiness that they feel that suggests that they need to do this movement in order to feel okay. Again, the therapist can simulate if necessary, and or the tic can simulate if necessary. And then we engage in that practice. And the patient, now we want to lift the finger before the tic occurs. The therapist monitors during this conversation again, gives feedback, and you continue with this until they've been correct about 4 out of 5 times. This process can really make it feel like tics are worse because the patient is intensely paying attention to them. So letting them know that it's going to feel like this prior to this process can make it feel less bad for them because you're normalizing the fact that it's going to feel worse. Then we move on to competing response training. So when we choose a competing response, we need to make sure that the competing response isn't relieving the urge because that's similar to the tic. We don't want to have that reinforcement, right, of having the tic relieve the urge, but we want them to be able to do this until the urge dissipates. So similar to if you have an itch and you don't scratch it and you make yourself distracted or do something else, eventually that itchy feeling goes away. We want that same thing to happen with our competing response. We should really focus on stopping that behavior of the tic at the very beginning of the movement. And we're going to teach or demonstrate the competing response after the child chooses it and practice the competing response. So in the example that we had with that young girl, if I was right and it actually started in her stomach, then that's where we would start with our competing response. If it really started more in her shoulders, then we would pick a competing response that started there. There are 3 rules for a competing response, and these are really important to pick one that's going to be successful. One is you cannot tic while you're doing the competing response, or at the minimum, it makes the tic less noticeable. So there are some that are harder to do or harder for the kid, and sometimes you can't find one that's going to completely make it impossible to do the tic. And if that's the case, we want to at least make it less noticeable. They need to be able to hold it for at least a minute or until the urge goes away, and they need to be able to do this anywhere. So for example, if you have that you're going to put your hands in your pocket, you can't do that in the shower. So you need to be able to do the tic wherever you are. And so you need to make sure that you have those considerations in choosing competing responses. And the competing response should be less noticeable than the tic. So if you have a competing response, but it's going to make people stare at you more than your tic did, that's also not helpful. And again, remembering we want to have a competing response that doesn't relieve the urge, but helps the student to be able to maintain that position until the urge dissipates. So when we work on making our choices for our competing response, we want the patient to come up with the competing response. So it's really important for them to be involved, both for their buy-in and their motivation and their willingness to engage in that competing response. So have the patient come up with one, and then have them go through each of the rules to determine if it meets all 3. Generally, the first one that they pick is not going to meet all 3 rules. So identifying which rule it doesn't meet will help them figure out how they might need to modify that competing response so that it does meet all 3. So then you can repeat this process over and over again until you find a competing response that fits all of the rules. If the patient really struggles with this, you can provide some options, but you really have to find one that the patient buys into or they're not going to use it. So they really have to be, yes, this is the one I want to use. And if they're not, then it's not the right competing response. So some examples of competing responses for motor tics. So for leg movements, One example would be to push feet into the floor. If standing, lock your knees. One for mouthfacial movements is to slightly clench jaw and press lips together. And with all of these, you can see that there's a little bit of muscle tightening on most of these competing responses. And it's important to make this light muscle tensing and not intense, because if they do them intensely for a long period of time, that's going to be uncomfortable for them. So we want this to be not an uncomfortable experience. For arm and hand flicking, a competing response example would be to lock elbows and extend fingers, so like make blade kind of hands on that. And head jerking, an example of a competing response would be to tuck chin slightly and tense neck muscles. So these are just some places to start if students are having trouble coming up with their own. They aren't the only things that you can do. And for some people, they end up not being the best one. So you'll have to sometimes be creative and try multiple options before you find the right one for people at times. Examples for competing responses for vocal tics, which would be sounds or words, tends to be deep breathing. So when you're engaging in diaphragmatic breathing, it's hard to talk or make sounds. So after you've chosen the competing response, you demonstrate that, and you demonstrate it while you time it. So you want to make sure that you have an internal sense about what 1 minute is, and that you're starting to teach the child about an internal sense about what 1 minute is. So in the long run, we're not going to always time this, but at the beginning, we tend to time it to start to increase that understanding about what that internal minute feels like. Then we engage in competing response practice. So during this, again, you either chat or play a game. The patient will use the competing response when they notice the urge or when they notice that they're doing the tic. So eventually we want them to do it when they have the premonitory urge, but it's completely fine if they've missed that and they start doing the tic and they use the competing response then. They hold the competing response for at least a minute or until the urge goes away, whichever is longer. So it's a minimum of 1 minute, and sometimes they have to hold it for much longer if it takes longer for the urge to go away. So you try to continue to engage in the chat or game as much as possible while they're doing the competing response, and how much this is possible varies depending on what the competing response is. And you continue to do this practice until the patient correctly uses the competing response for that tic about 4 out of 5 times. Some common mistakes in choosing competing responses include not focusing on the beginning of the movement. So if we start in the middle or near the end, it's going to be less successful. Being impatient and choosing the competing response for the patient instead of letting them work through this process. Not giving feedback during practice, and not requiring the patient to hold the competing response for at least 1 minute or until the urge goes away, whichever is longer. So again, sometimes a minute isn't long enough. Every week, they'll also work on homework. So they need to work on using that competing response. They use this during both planned, scheduled times and unplanned times. So during the week, during your session, you'll pick some times that they have some focused practice doing it. So like maybe like right after dinner, they spend 15 minutes really working on using their competing response. But we also want them to use it throughout the day when they experience the tic as they remember. We want to make sure that they're using the competing response for the new tic that we're working on and all the other tics that we've already worked on. We also want to review the functional interventions to make sure that, again, they're using those functional interventions for all the old tics and the new tic that we're working on this week. So eventually, during the sessions, we begin to work on relaxation. So this is not a primary part of CBIT, but it is a supportive component. So the first week we work on diaphragmatic breathing. So this is, again, just learning to breathe from the diaphragm, long and slow. Some examples about things that people use are blowing out the candles, blowing up a balloon, 4 square breathing. So you can use whichever diaphragmatic breathing techniques you like and you think are going to be beneficial for that particular patient. And then the following week, you work on progressive muscle relaxation, tensing the muscles, and then relaxing them. So this is quite an old article, but they have some really nice ways to think about muscle relaxation for kids. For hands and arms, they have them squeeze lemons as hard as they can to make lemonade. Arms and shoulders, stretching out like a cat. Shoulders and neck, going into your shell like a turtle. For your jaw, chewing on a jawbreaker gum. Face and nose, you have a pesky fly and you're trying to get off of your forehead. There are 2 stomach ones. One where you tighten it because you're afraid that a baby elephant's going to step on you, and one where you pull it in because you're squeezing through a fence. And then the legs and feet, they have you squishing your toes into the mud. So this is a nice way, but it's just one tool that you can use to work on muscle relaxation. And then self-monitoring. So again, this awareness is necessary, but not enough. We really need to make sure that they're working on using the competing responses and that they're starting to get a good sense for themselves about when they're ticking and how well they're using their competing responses. So we want them to note the frequency differences throughout the day. Like, are there times when things are getting worse for them or better for them? And we tend to have some times where we ask them to really pay attention. So 1 or 2 times a day, they like really pay attention to their ticking and how that's going. We want them to really pay attention to situations that increase them. So is it being called on in class? Is it watching television? So just again, making them more aware of their own tics. After the competing response training begins, we also want them to monitor their use of the competing response and the effectiveness of it. So sometimes they'll use a competing response for a week and they're like, I don't think that was the right competing response. It didn't seem to be effective. And so then you'd go back and help them pick a different competing response for that tic. So our self-monitoring progress, again, we schedule about 30 minutes, 3 to 4 times a week of intentionally monitoring that tic. And they try to schedule these during high tic times as much as they can. They tally each time a tic occurs during those sessions. And their parent or support person should also observe and monitor so they can start to see how accurate they are compared to another observer's perception about their ticking. And we are also going to monitor our progress monitoring for that tic hierarchy. So we're looking at those SUDS ratings every single week on all of the tics that they've had from the very beginning. And we use this as a motivator because it often feels like tics aren't improving. So individual perceptions about how this is working often say, kids will say this isn't working. So we can look then at the actual data from the sheet to show them that it is working. So I have an example here from a student I worked with where I just have the data that we had for his tics across 7 of the sessions here. So you can see I had him name his tics so that we could easily talk about them throughout the time and monitor the progress. So you can see I had finger crossing, leg shaking, freeze stomach, head back, and hit head with hand. And you can see that lots of these started at 10, which suggests that it was really troublesome for him and caused him a lot of distress. And some of them, one of them you can even see stayed up there for a good bit of time. So 3 weeks before we were able to get that to go down. And then it completely went from 10 to 0, which is unusual, but that's what happened for this kid. And you can also see that as we're going along, there were some new tics that entered. So the hit head with hand didn't enter until session 4. So as you go along, there'll be new tics added, and where they are on their ratings can vary and go up and down. But looking at this, when I asked him how it was going, he didn't think it was working very well. And then we looked at the actual data, and he saw that actually his ratings across time were getting better. And in the last couple of sessions, we start to make a relapse prevention plan. So after the end of CBIT, they're still going to have tics that come. So we want to have some plans for them so that they can continue to use competing responses effectively. So you work on anticipating and planning for symptom reoccurrence. So what are things coming up that are likely to make their tics worse? So again, exciting things, even good things, can be problematic. So maybe they're going on a big vacation, or maybe they're graduating from high school, or some big thing that's happening that's likely to either cause excitement or stress that will increase their tics. You review the strategies about how to use the functional behavior assessments and how to identify the tics and come up with competing responses. Help them to develop realistic expectations. So the tics aren't just going to automatically stop because we've done CBIT. They're still going to develop these, but they need to remember that they have this plan, things that they can do to support their process. We also want to plan booster sessions. So after the 8 sessions, we usually then schedule a session about 2 weeks out, and then a month later, just to make sure that they are have some supports. And often it's good to let students know that if some big things coming up, that they can always come back for just a booster session. So maybe you've been seeing them through the beginning of junior high. And then like 2 years later, they're about to enter high school. So they might come like, that August to prepare, get a booster session to support them during that big transition where they're likely to have some struggles. And then you provide referrals as necessary. So again, there's a lot of comorbidity with tics and Tourette syndrome. So if they have other challenges that need to be addressed, you can send them out to another physician or therapist if you don't feel like you have the capacity to support them in that. And then the article on the relaxation is this relaxation training for children. So it definitely has, it's a complete script. So if you feel like you need some extra support in providing progressive muscle relaxation for kids, this is a good resource. All right, and that's it for now. So I have time for questions.
Okay, and while you're posing your questions in chat, I'll just launch the post evaluation.
So the question is, do you meet with the parents and child together for all sessions? And this is somewhat variable. For younger children, yes, you generally do that. For older children, you meet with the parents definitely for those functional behavior assessments because they have a lot of responsibility for that component. And then for the actual doing the competing response, it depends. So I've worked with high school kids who wanted their parents in there. So we definitely include them when we want them. If not, you would bring them in at the end to make sure that they know what the competing response is and the tic that you're working on. But you can work on the actual competing response with the kid alone, if that's the kid's preference. The next one, if a client had comorbidity with OCD and ADHD, how would you target which to do first? So we talked about this a little bit in the first session. With OCD, you probably want to treat it at the same time and or first. So making sure that they have some of those obsessive compulsive challenges managed before we work on the tics. And ADHD, it depends. So if the child is able to engage effectively, that's what's important. So if their ADHD is so unmanaged, that they're not able to engage with the therapy, then you'd want to make sure that you had that somewhat managed. But then otherwise with ADHD, you just would have somebody else treating the ADHD, or you would be treating that separately. And you would be working on CBIT at the same time with some of the modifications or accommodations that we generally give to support kids with ADHD. With coprolalia, how do we determine if it's a tic? We have a kiddo who swears a lot, and I am unsure how to determine this. Yeah, so I think on this, you have to kind of rely on the kid to tell you about whether or not it is a tic. Yeah, so it is possible that a kid who has Tourette's would use it as an excuse to swear. And I don't know that there's a good way to tell for sure whether or not they're being truthful about that. The next one, when do you move on to the next tic? I'm assuming you'd want to wait until the patient has made some progress on the first tic. So the general progression is that you work on a tic every week, but the program is flexible. So if things aren't progressing and they're like, this competing response didn't work, you can continue on that one tic. Yeah, so you definitely don't have to wait until the tic goes away or they get down to 0. But if they feel like the competing response is helping, then it's okay to move on to the next tic. How do you handle situations where practice is not occurring outside of sessions? So I would really spend some time digging into what's going on, what's interfering with their ability to engage in that practice. So is it that the competing response we picked wasn't a good one, and they're like, yeah, I'm not doing that? So if that's the case, we just work on a new competing response. If it's more that the kid is like, I don't really care, like the tics aren't bothering me, then you might want to revisit whether CBIT is the appropriate intervention for right now. If there are some other things in the life of the family, then you might want to just kind of identify what's getting in the way and what are some things that we can do to overcome that. So it would be really a collaborative process of working with the family to determine the things that are interfering with practice, or the kid and what's interfering with the practice, and how you can overcome those obstacles.